I think we're just about to kick off. So for those of you online, you're joining in part 3 of the Scirocco Final Conference. Welcome. Okay, so we're going to kick off, as I was saying before lunch, we're going to kick off now with the next application of the Scirocco tool, which is to the assessment of the maturity requirements for a good practice. So Stuart's going to give a very quick overview of how to use the tool. And then we are going to hear from Kike Barrett, I hope that was pronounced properly, and his experience of using it within the Basque Country and applying it to a good practice from the Basque Country. So, Stuart?
Thank you. Okay, so I think one of the really critical outputs from the European Innovation Partnership on Active and Healthy Aging has been the repository of good practices, because it actually says here are concrete examples of things that one can do to improve the delivery of integrated care. And so one of the things we started to look at was how can we get a way of assessing good practices? And what we came up with was there's this idea of maturity requirement. And what I'm going to say is very much along the lines of what Christina said this morning, but there's one subtle difference, which is this notion of maturity requirement. And what maturity requirement is based around is the idea that any good practice will require some features in the health system that it's embedded in. And what this process is about interrogating the good practice in the health system to see what those features are. And the assessment of the level is how much maturity do you need in order for those features to be likely to appear in the health system? Yeah, so it's about kind of digging about the relationship between the good practice and the health system. So what I'm going to say is pretty much the things that we heard this morning from Christina. But here, yeah, if we look at number 2 here, the experts, once you've got the expert group, perform the assessment and they identify relevant features of the healthcare system for the adoption of a good practice. So the idea is this idea of identifying relevant feature, yeah, and saying, and that's where the assessment, that's how the assessment should be justified. The experts share their individual questionnaire, and then a workshop's organised and they discuss and reach consensus about what the key relevant features are and what that means for the level of maturity that's required in the health system in order for that good practice to be adoptable. Yeah. And we have the same sort of idea again. We have a multidisciplinary team. We have, let's say, a practitioner perspective and a managerial perspective, but we might have other perspectives as well if we've identified them. They go about performing an individual assessment, but this time, here, if you look at this, you'll see that what we've got here is that you actually have to identify the healthcare system that the practice grew up in, yeah, and you have to say what the name of the good practice is. So when you start doing an individual assessment, you say, I'm looking at this good practice and it fits into this health system. So here you start to perform the individual assessment, and if you click on the information thing about this, it says, what is a feature? A feature is a concrete thing or requirement in the healthcare system that is needed by good practice to be implemented and or transferred. Yeah, so that's the key element here. So everybody goes off, they do their thing again, and then people here, if you look, this one in the little box underneath the scale, there's a box that says governance structure that spans primary and secondary care is important for this good practice. Yeah, so this is we're looking at the governance axis here. Governance is adequate to support teleconsultation and limited teleprescribing. So those are features in the healthcare system. They're not part of the good practice, but there's something in the healthcare system that the good practice draws on in order to do that. So each of the individual assessments will have this kind of thing in each of the boxes for each of the dimensions. And then there's the negotiating and reaching consensus process where people look and discuss it here, yeah, and they overlie, and then the discussion goes on. You know, so here, this is about the pain clinic that you're just about to hear about. So capturing the pain clinic decisions took work in the personal health record, and then governance is well developed, there's nothing new here. And then the administrator comes in and says, ooh, this pointer's not pointing to quite the right place, should be somewhere over here. You can say it took months of negotiation with the GPs to agree on teleconsultation. So they might have 3 different perspectives. And they're arguing really about how easy or how difficult it is for those features to be available in the health system, you know, and that is a reflection of its maturity. And actually the level of maturity requirement required by the good practice. So again, there's a decision, here it's in the middle, and there's a discussion around each of the dimensions, and eventually you get to this black band, which is the agreed level of maturity requirement for the good practice for, in this case, the pain clinic in the Basque Country. And if you like, that black border, if your assessment for your healthcare system encloses that, so in other words, if that kind of fits inside, then you might say that's a candidate for it being the easiest in some sense for us to adopt that good practice. So in other words, of course there are still going to be issues, but in some way, if your assessment of the maturity of the health system comes outside of the assessment for the maturity requirement of your good practice, then the two should fit together reasonably well with a reasonable amount. Whereas if there's something where there's a great big piece of the good practice maturity requirement that sits outside the boundary for your health system, then you can expect trouble in that area, yeah? And maybe it needs work in order for you to be able to adopt that good practice. So features capture what the good practice needs in the environment. They capture the originating healthcare system in some detail around how it provides for a particular good practice. And then adoption and transfer involves exploring how to reconcile the features needed by the good practice with those available in the receiving healthcare system where it's going. Yeah? And as the population of good practices grows, the healthcare system feature sets become more and more complete because you're probing them with more and more good practices. So in some sense, as you probe the healthcare systems with the good practices and say, what is it that the healthcare system provides to support these, you get a fuller and fuller picture in the tool of what the healthcare system is able to support. And now we're going to see some work on the pain management. So
okay,
here he comes.
Yeah, thank you, Stuart. That was great. So we have now got Ricky Barrett coming up to give us his some of the features and challenges around the good practice on the pain clinic, and also how you have applied the Scirocco tool to that.
Yes, thank you very much. Well, first of all, I want to thank your invitation here, and especially to John Charamendieta, who has been a big help and a friend. I'm here to explain you our clinical practice, how we assessed the Scirocco tool and the results. And first of all, I want to explain you who we are. This is the same Basque Country that Igor showed before, so I'm not going to repeat it again. But in the assessment process, in the first step, the work chosen to select it as a good practice was ours, and it's called integrated approach in pain management. I'm an anesthesiologist, I'm a clinician, and I usually manage patients with chronic pain. So that's my job, and I want to show you a little bit about how we work daily, so you can understand afterwards the assessment with the tool. We work in 3 buildings in the south of Euskadi, of the Basque Country, and we attend more or less 400,000 population with some problems. This slide could be start with something like once upon a time there was a pain clinic with problems. We could have said, Houston, we have a problem, but instead we decided to be our own Houston, and we met each other, the doctors. We are 6 doctors and 4 nurses. We had a meeting and decided to change the problem, because in 2014 we had some problems, but mainly there were 200 patients, more than 200 patients waiting to be at our pain clinic, and we had no time, no place to receive them. So we agreed we have to change the management model. There was not only a problem of number of patients, but a problem of kind of patients. Some of them have reduced mobility, and you don't know Vitoria, the place where I come from. It's placed in the north, and it's not the typical Spanish good weather city. We have snow and rain as common conditions in our place. So we tried to plan an integrated approach using, very important, the electronic integrated clinical record, planning two kinds of attention. First of all, presential attention, like always, and non-face-to-face consultations. How did we do it? Well, we changed it after a meeting with other professionals from primary care, from hospitals, and with patients too. So we started to work with non-face-to-face consultations, like I am going to show you in the next few slides. The first of all is the telephone calls. This changed a lot our way of monitoring our patients, because nowadays 1/3 of the follow-up in our pain clinic is performed by telephone calls, and it has reduced critically the unexpected visits or the unexpected calls from patients. This is a real agenda of telephone calls. We also have remote controls of non-patients, so we can check their evolution, just watching our diagnostic tests or watching how they are receiving medications, and we just get in touch with the patients if it's really necessary, if it's a reason. They know we are doing that. Meanwhile, we are doing. We also make video conferences, nothing to explain about that. And very interesting, using the health folder, patients can write questions or write a diary of their pain, so they send us through the health folder, and they get our answers without the need to come to, they don't need at all to come to the pain clinic, so they receive the answers at their own homes. This is an example of doubt. It's written in Spanish. My name is Enrique, but they call me Dr. Varez. She's asking me a question. I answer them directly. And this is another example of a diary from a patient. I'm not going to put the diary, of course, but we read the diary and take notice if we have to telephone them or to cite them at the pain clinic. And also, we can prescribe pain-related applications for smartphones or tablets in order they can improve their quality of life. The first thing we noticed with that is using non-face-to-face consultations. We improved the time for directly consultations for patients. So that was not only the first result, but we were surprised about how the delay of patients improved. We started about 400 days of delay, and it went down to nearly 2-3 weeks in the first 3 years. Continuing with the assessment of the tool, I think you have seen this before. We identified 4 people, very different from one each other, and we received a very clear introducing meeting, and then we made the individual self-assessment of the tool. And the results was what you can see in this slide. I want to show you this one. It's my result. I think you have seen these pictures before today. The other one at my right is the result of my boss. And this is my boss, the boss of my boss. And that was a general practitioner. So you can see the results are quite different. And that's good, because we have to celebrate the workshop for consensus, and the message is you can get consensus even although in that meeting your boss and the boss of your boss are present. And that was our result. And there were some things relevant, really relevant to declare. And for example, we think that the use of a fully integrated electronic health record that must be accessible to all professionals so they can share the information. The use of teleconsultations between primary care and the hospital, it's relevant. The use of personal health folder is accessible to the whole population so that they can intercommunicate between them and the professionals. Very important to have cohesive structures between primary care and specialist care, and common communication and easy communication between them. And it's desirable. The social level is integrated too, but it's not already. And the personal health folder is used as a tool for patient empowerment, as they can use it freely. Very important, but not as relevant, are considered what you can see in the slide, some functional integration between health care levels. You need a working group, but you also need a leader. So to have some funding to plan and implement the intervention, and screening requests and appointments about the prioritization according to patients' morbidity risk. So key findings and conclusions are the consensus workshop has been key to achieve the results. As I said before, the features can reduce the variability. We are clinicians. We have simple minds. We need simple language. The language used in the tool is somewhat complicated for us. A further refinement could be beneficial. And at last, I've written a desire that I would love to know not only the degree of transferability, but the level of effective transfer achieved between regions. I imagine it will take years, but we can wait. Let us know. Thank you again for your attention.